Hi, welcome back to week 3. This week we're focusing on the ears, nose, and throat. So here we go. So the first thing I wanted to do was just do a quick review of the basic anatomy of the ear, nose, and throat. And I found this great little video on YouTube that gives a really beautiful visual review. So just watch this quick video just to get a good review.
The ears, nose, and throat have separate but related functions. The throat is a passageway that carries food to the esophagus and air to the lungs. At the entrance to the windpipe, the voice box contains vocal cords that open and close to produce the sound of the voice. This is covered by a stiff flap of tissue called the epiglottis, which prevents food from entering the lungs. The ears are important for both hearing and balance. The outer ear directs sound waves to the eardrum, which vibrates against tiny bones in the middle ear. This stimulates nerve cells in the inner ear to generate nerve impulses that travel to the brain, where they are perceived as sound. Components of the inner ear, called the vestibular system, gather information about the position and movement of the head to maintain balance. The nose is the main passageway for air into and out of the lungs. The nose warms, moistens, and cleans air, and is also the organ of smell, which is an important component of taste. Finally, the sinuses are air-filled spaces that open into the nasal cavity, which reduce the weight of the facial bones and skull, while also maintaining shape.
So that was just a quick recap. The important thing is, you are very aware of your landmarks. So let's talk about a few things. First of all, in terms of the ears, okay? We're looking at the bones of the ear, the malleus, the incus, and the stapes. Those are important to know. The stapes is the smallest bone in the body. The interesting thing about the ear is everything is so intricate and small. It's amazing, like how little issues a lot of people have compared to how many you probably could have with the fragility of the ear. But the important thing, when I first started looking in ears, I just sometimes would get overwhelmed. Same thing with eyes, because I just never really knew what I was looking at. So the important thing is to know your landmarks. Right here, over here in this diagram, the cone of light, very important. You should be able to see that. The eardrum itself is very kind of gray and shiny looking, and that's what a healthy tympanic membrane looks like. Later on, we're going to look at a video of what a normal ear looks like versus an ear with an infection. And you'll get to really see, what the assessment looks like in real life. So remember, your tympanic membrane, it's got like this translucent off-white gray color with the cone of light intact. The lateral process of the malleus is located at the upper quadrant of the tympanic membrane, and the pars tensa is located on the lower aspect and it appears to bulge slightly. It is the area of the tympanic membrane where the cone of light is actually visible. Okay. In terms of your ears, we're talking about the pinna, which has a large amount of cartilage. Okay. Blunt trauma can result in a hematoma in that area. So as soon as you see that, you need to make sure it gets drained to avoid damage to the cartilage of the ear. Because if you leave it, it can result in something called cauliflower ear. Remember terminology in terms of the ear. Cerumen is considered earwax, and the color can range from yellow to dark brown. Okay, then we have our nose. All right. The big thing in the nose, you want to look at the turbinates. Only the nasal terminates, the inferior ones, are usually visible. The medial and superior turbinates are not visible without special instruments. And remember, abnormal turbinates are bluish, pale, or boggy. And that's usually seen in your allergic rhinitis. Remember, the lower third of the nose is cartilage, and cartilage does not regenerate. So just keep that in mind. And then you have your septum in your nose. Perforation of the nasal septum can result from drug use, and it does, or from blunt trauma, and it does happen, and that needs to be referred to a plastic surgeon. And then, of course, you have your sinuses, which are air-filled cavities in the skull. You have 4 types of sinuses: your ethmoid and maxillary, which are both present at birth. You have your frontal, which develops by age 5 years old, and then your sphenoid, which develops by the age of 12. By the age of 12, all sinuses, a child's sinuses are nearly at adult size. And then, of course, we have our mouth. Now, in terms of our mouth, we're looking for pink to dark pink and moist in terms of the mucous membranes. You're always checking the mouth for any kind of ulcers, fissures, leukoplakia, or inflammation. If you notice that your patient's gums are red or swollen, they may have gingivitis, where their gums bleed a lot when they're brushing their teeth. Or it could be a cause from medication such as Dilantin. The tongue should not be red or swollen, and a normal adult has 32 teeth. Okay, and we'll talk about the abnormalities as we continue on. All right, so what are we doing in practice? So I wanted you to just see what a normal, healthy patient looks like during an ENT exam. This is a very short video, but this practitioner does an amazing job, not only assessing the patient, but explaining as she's going through what she's looking for and what she does not find. Because remember, when you're doing your exam, sometimes there are things you need to say that that you checked, like you're documenting, okay, she doesn't have any maxillary tenderness. You want to make sure you point those things out during these sort of exams. All right. So just watch this video and listen to what she's saying. And I would encourage you to actually think of yourself as this person, wearing a white lab coat, put yourself in the shoes of this practitioner, because at some point you too will be doing this.
Okay, now we're going to check your hearing. Okay, I'm going to have you close your eyes, and I just want you to hold up the hand on the side that you hear my fingers. Okay. Very good. Okay, you can open your eyes. Now I'm going to inspect the ears and palpate the ears for any lesions, lumps, battle signs, ecchymosis, mastoid process tenderness, tracheal tenderness here. Is that okay?
Yeah.
All right, and we'll take a look in the ears. Okay, noting that the canals are patent. The team has visualized. It's pearly gray and translucent. Landmarks are also visualized. We'll do the same thing on the other side. Tender there?
No.
Here? No. Okay, take a look in the ear. Okay. And again, the landmarks are visualized with the cone of light, the umbo, and the malleus, and no signs of fluid in the middle ear. Okay, next we'll move on to your nose. Okay, I'm just going to include one nostril. I want you to breathe in. And now the other side. Good. I'll do a general inspection of the nose, noting no deformities or lesions on the nose. Palpate the nasal bones and the cartilage. Everything appears healthy and normal. And then we'll take a look in the nose. Okay. Noting that the mucosa is pink and moist, and no septal deviation. Terminates are normal. No lesions or polyps. Very good. Now I'm going to inspect the oral cavity. You can go ahead and open your mouth wide for me. Okay, and I'm looking at the buccal mucosa, and have you say, ah. Palate elevates symmetrically. Cranial nerves 9 and 10. Have you lift your tongue up to the roof of your mouth, looking at Wharton's duct in the floor of the mouth. Good. And go ahead and relax your tongue. And we'll look at Stenson's duct on either side. Okay. And any signs of distressed teeth or tenderness there. Good. Now have you stick your tongue straight out at me and move it side to side. And cranial nerve 12 looks great. Okay, now I'm going to get a glove so I can actually palpate the oral cavity. We use a bimanual technique for this so that we can really feel the mucosa and tissue. Okay, have you open your mouth wide for me? All right, and I'm just feeling the buccal tissue here, the sulcus and gingiva, floor of the mouth, okay, and the other side. Good, and everything feels healthy and normal. Okay.
And that's it. Quick review on what an exam of a healthy patient looks like. Okay, So what are we seeing with most common chief complaints with ear, nose, and throat? So we get a lot of oral sores and we get a lot of sore throats when they come in primary care. 20% of your visits to primary care are due to oral and pharyngeal problems. So what is the cause? It could be infectious, it could be immunogenic, it could be inflammatory, traumatic, or malignant. In terms of your sore throat, the most common causes are strep or viral. You get upper respiratory infections, pharyngitis, herpes simplex, strep, the flu, you get thrush, candida, lots of things. So really, when you're looking in that mouth, you're looking at the mucosa for any kind of sores, any kind of discolorations, lesions, bumps. Those are things we need to figure out and follow up with very quickly. Okay, so otolgia. That's ear pain. It could be temporary or permanent. There could be mechanical reasons, conductive, which are often reversible, or sensorineural. You always want to look in those ears to make sure that they don't have a lot of earwax, or what this is called impacted cerumen as a culprit. A lot of our elderly patients get big time buildup of wax, so that it could definitely be impact people who already have hearing issues. A buildup of wax is a big thing. There are over-the-counter Debrox ear drops that you can have patients start with, if they want to try that, and then if not, you can go as far as irrigating the ear if needed. It occurs with aging across the gender and ethnicities. So that's one, ear pain. And then another thing we have is impaired hearing. It could be bilateral versus unilateral. You want to know certain things that could be causing impaired hearing. Could be infection, eustachian tube dysfunction, sinusitis, or TMJ. A lot of people with TMJ will have impaired hearing, so you need to follow up with that, and sometimes they need to be referred to a dentist or to have treatment for that. A lot of the times people get mouth guards, which helps alleviate that quite a bit. Primary otologia is from within, and it could be referred from other structures. Another big complaint is tinnitus, all right, ringing and buzzing in the ears. A lot of the times you're going to see this with veterans or anybody who's been in combat, any of our soldiers. They get any kind of head injuries or loud explosives or gunshots. Anything loud near the ear can lead to this problem. It can be very debilitating at times. Besides just hearing loss, you could have neuromas, Meniere's, drug toxicity, could be a metabolic issue, neurological, psychogenic, could be from, like I said, drug toxicity. So always make sure you're looking at your patient's medications when they come in with complaints of tinnitus. Okay, next. So again, all right, so we have tinnitus here again. Then we're looking also at other chief complaints that people come in with: mouth sores and hoarseness. A lot of visits are for mouth sores. So it could be infectious, immunogenic, inflammatory, again, traumatic or malignant. Hoarseness in terms of the voice, you can have a pitch vocal change. With aging males, the voice tends to get higher and weaker. With aging females, it tends to get lower. Hoarseness is typical with common upper respiratory infections. Obviously, if you're screaming or hollering, you can have hoarseness. Smokers, big time, and anybody with GERD. You have to be very careful with hoarseness because it's a cardinal sign of laryngeal cancer. So it's definitely something you need to follow up with if a patient starts complaining of hoarseness that's going on for an extended period of time, especially if there is a nagging cough associated with it or any difficulty swallowing. Okay, hearing loss. Obviously, that comes with the aging. It's greater in men than women sometimes, but you're going to always look for family history of that. You want to see if there's any other associated symptoms as well as the hearing loss. Like, are they also having vertigo? Are they getting ringing in the ears, the tinnitus, pain? Are they complaining of dizziness or loss of balance? Do they get any headaches? These are things you want to review with them. Your review of systems should also include questions about your cranial nerve function. You're looking at the patient. Do you notice that one side of the face sags over another? Do they have loss of taste? Have they been exposed to a lot of noise? Like this is where you find out if they were in combat, if they were exposed to any kind of head injury or loud explosions, which most of them are, if they are. You want to know about any toxins the patient may have been exposed to, and again, looking at their medications. So it's important to know the differences between your conductive hearing loss versus your sensorineural. Okay, usually the sensorineural is age related. It's definitely associated with Meniere's, okay, or tumors, trauma, and of course, any kind of diseases such as syphilis or mumps. Okay, it's often irreversible. So it's important that you find out what the cause of it is so that you can, if it can be treated or reversible, we can handle that, or we'll deal with that, I'm saying. Conductive loss is when you have a passage of sound through the tympanic membrane and inner ear that's impaired. Again, a lot of the times with conductive loss, it's due to the buildup of wax, the cerumen impaction. So of course that's reversible. We flush the ears, the wax comes out, and their hearing improves. Sometimes it's related to a perforated tympanic membrane, or TM. Chronic ear infections can cause conductive loss, congenital abnormalities, and then, of course, any fractures to the temporal bones can cause hearing impairment. Okay, next. So hearing loss exam. So we have our otoscopic exam. You're looking in for earwax, so you want to say no obvious cerumen, and you use your tuning fork test with your Weber and your Rhine and your tests. You want to make sure you know how to do those tests well. And review those, because there are a lot of questions, not a lot, but there are definitely questions on the boards about Weber versus Rhine. Okay, so remember, the Weber test is done by placing the tuning fork midline on the forehead, and to find a normal Weber test finding is no lateralization. So lateralization is when you hear the sound in only one ear, or the sound is louder in one ear, which is an abnormal finding. So again, lateralization is what you're finding on a Weber test. And if you shouldn't find it. A normal finding is no lateralization. But if you did have lateralization, it would be that you're hearing the sound either in only one ear, or the sound is louder in one ear, which is abnormal. Okay. And then with your Rhine test, you're placing the tuning fork first on your mastoid process, then at the front of the ear. And you're going to time each area. And a normal finding in the Rhine test is that the air conduction lasts longer than the bone conduction, meaning you can hear longer in the front of the ear than on the mastoid bone. Okay. Okay, so in terms of hearing loss, we want to determine if it's a treatable cause. And obviously, if it's a treatable cause, we're going to treat it. If we determine it's sensorineural hearing loss, refer to the otolaryngology for diagnosis and management. For presbycusis, we're going to refer for audiometry to an audiologist to see if we need a hearing aid. Consider other factors too in terms of this. You want to make sure they're safe, they're not getting depressed or isolated because of that. And of course, if it's a ruptured tympanic membrane, we need to refer to an ear, nose, and throat doctor. We want to definitely educate to avoid loud noises and, deter any ototoxic drugs to this patient. Okay. So tinnitus, again, ringing in the ears. So it does happen with aging. It's common in people in their 40s to their 70s. It's greater in male than females usually. It's more frequently found in Caucasians than African Americans. 90% of patients with hearing loss experience tinnitus, and it's a very, very debilitating for some people. It can be awful. Like, to constantly hear ringing in your ears is really not a good thing at all. And you really have to give a lot of just encouragement to these patients. So diagnostics, you're going to run a CBC, a metabolic panel, thyroid. You, of course, if you see any ear drainage, you want to culture that, and you may need an MRI to make sure the ear pathology is all intact. You want to make sure you're looking at other causes, differential diagnoses, such as any systemic issues, cardiovascular issues, neurologic, metabolic, again, medication related, and of course, aging. If it prescription for tinnitus is dependent on the cause. So obviously, if you can figure out what's causing it, you want to remove that. So if it's an offending medication, you want to take that away. Treat any disorders. If it becomes severe, you can treat with Elavil, 50 milligrams at sleep, or meclizine, especially if there's vertigo involved as well. Some things that you can do to kind of try to help the patient manage the symptoms of the tinnitus would, is play background music to try to, kind of cover up the ringing at some level. You want to make sure they avoid excessive caffeine, chocolate, alcohol. Keep in mind, we want to limit anything that could possibly make it worse. So they may need to figure out for themselves if there are certain things that do make it worse that they could try to cut out from their diet. And of course, if they could get good sleep, that always helps everything. You want to have them follow up with an audiologist or an otolaryngologist, or anybody who could specialize to help them deal with this. Okay, so Meniere's disease, it's not the most well understood disease. They don't really understand what causes it, but they do know it's a peripheral sensory disorder of both the labyrinth and the cochlea of the inner ear. So vestibular and auditory dysfunction. So you get, with Meniere's, you get recurrent attacks of tinnitus, vertigo, and a progressive hearing loss. So these patients have it rough because all of a sudden they'll have a lot of ringing in their ears. They'll get like this spinning sensation and they just start to lose their hearing. It's rough. It's not life-threatening, but if it's untreated, acute attacks typically last over 4 hours. It can last up to 4 hours, and it does reoccur like pretty frequently. I noticed it mostly in my patients about 50 and up, but this says 30 to 60s. It's rare in young children and adults over 70. So multiple possibilities of differential diagnoses. So consider other things besides just Meniere's before you start diagnosing this. It could be benign paroxysmal vertigo, which is more common than Meniere's in elderly people with dizziness. So just keep that in mind. BPV, or benign paroxysmal vertigo, is accompanied by nystagmus when laying down or turning over in bed. So that is something you want to just examine on the patient to differentiate the diagnoses. So another clinical pearl, as we say, is that Meniere's is associated with hearing loss, whereas BPV does not present with hearing loss or tinnitus. So that's the difference between those two. You're going to examine these particular patients with an otoscope. You're going to do your Weber and Rhine. You're going to do a full head, ears, nose, and throat exam, neuro exam, cranial nerve exam. We're going to do some vestibular function tests. Obviously, we'll refer to them for audiometry or psych if needed. So we could treat the Meniere's attacks with a lot of rest, quiet rooms. You want to make sure they're kind of lying down, protection from falling, because remember, they do get that vertigo, which definitely can cause falls. So we want to restrict sodium, caffeine, and alcohol. Remember, these sodium, caffeine, alcohol, they all cause inflammation, no matter what disease process you're talking about. So those are things you want to avoid in any of these kind of diseases. So it can be treated with streptomycin or gentamicin. Ablation therapy may be appropriate to reduce unbearable vestibular symptoms. Obviously, we're going to refer to a specialist if the symptoms get worse, and they may require neurology. I probably would refer them to neurology, as soon as the diagnosis is made, because sometimes it's not always easy to get these appointments in place with the specialist. So keep that in mind. Obviously, you want to make sure you tell them symptoms that they need to report to you if anything gets worse and is not alleviated with their normal tactics of rest. And you want to make sure they let you know, obviously, if they pass out, if they fall, if they develop a fever, or obviously if they have a seizure. Okay, next we're going to get into acute otitis externa, also known as swimmer's ear. So this happens a lot in the summer, obviously, when kids and adults are out swimming in the pools and the ocean. People who are at much higher risk are people who are immunocompromised or diabetics. Lots of swimming and pools with lots of chlorine, that you tend to see more infections with that. So also things that can cause this type of infection are a lot of use of cotton swabs, what are those called, Q-tips. So you have to be very careful in educating your patients with Q-tips, not to push in too hard or do excessive use of it, or constantly picking in their ears. So the cause of swimmer's ears is Staphylococcus aureus or Pseudomonas aeruginosa. The hallmark symptoms are tender tragus and otolgia. They could be itchy, pruritic, they could have drainage. Sometimes you see like white, fluffy yellow, edematous canal, and you may not even be able to get your see in the ear, but don't insert the otoscope because it would definitely hurt a lot. This is a painful thing. Swimmer's ear is painful. I don't know how many of you have ever had this. I've had it a bunch of times when I was little because I was constantly swimming. So, ways to prevent it are to get something called swimmer's ear drops, which they sell over the counter, and it basically just dries. You put in a couple of drops after you go swimming in each ear, and it basically dries the ear out, any water that's in there. So that can be something you encourage your patients to use who do swim a lot or do get this a lot, because it'll help prevent it to begin with. So some emergency red flags that you definitely want to pay attention to is mastoiditis. That's a big deal. If you notice any swelling outside the canal, or they have pain in their jaws, if you notice any swelling in their lymph nodes, fever, malaise, if they are diabetic or immunocompromised, you definitely want to just make sure a differential diagnosis you're ruling out is necrotizing externa or malignant otitis externa. So treatment with an earwick. For some patients, inserting a cotton earwick in an ear is helpful. It remains in the ear and holds medication against the canal. So basically you put your drops in, and then you can put this little piece of cotton in your ear just to keep everything in there. You don't want it to be packed in, just very gently put it in there, place it in there gently. So obviously you want to be able to see the wick, the cotton still there, so you can pull it out if you need to, but it's good to help keep the medication in, because sometimes you put the drops in and they just fall right out of the ear. So this will help keep it in there, and you can even saturate the drops on the cotton and then put it in there too if you need extra use of the medication for that particular patient. Sometimes the wick falls out because the swelling comes down in the ear. That's normal. Just check it, make sure it's clean, and you can put it back in if you need to. Okay, so like we had said, with management of the hearing, otitis externa, you may require it if the earwick, if the ear is swollen, so you gently want to cleanse the exudate and apply the wick. You could put heat or ice locally applied to the outer ear to help alleviate any pain and swelling. Analgesics like Tylenol you can tell the patient to take, or ibuprofen. If you needed something stronger, such as acetaminophen and codeine, Tylenol #3, you could do that. But you want to be careful with those, of course. So antibiotic and antimicrobial drops, the cost varies widely, that's for sure. So you want to make sure you know what your patient's insurance will cover. So we want to make sure we're educating our patient on good ear hygiene, keep the ear dry, avoid swimming or submersion of the ear underwater for 4 to 6 weeks. And we want to watch for any signs and symptoms of recurrent or worsening symptoms, because obviously that indicates the infection is worse than we thought. So make sure they're watching for fever or any other symptoms that are worsening, to make sure they follow up with you. They also have to be very careful about going into airplanes, because remember that pressure changes and can also cause a lot of pain on these patients. So they want to avoid flying. Chronic otitis externa. Okay, so you may see granulation tissue and evidence of long-standing tissue. You want to probably make a referral to dermatology if it is recurrent, And if you do notice any white fluffy exudates, the likelihood is it's fungal, and that's when you would prescribe fluconazole 200 milligrams the first day, and then 100 milligrams for 3 to 5 days after that. And we definitely want to refer to an ENT if we have this any kind of chronic issues with the ear. So here's a review of the medications. There's a lot of great charts in your textbook on the common antibiotics for all of these issues. I'm not going to really read them to you. You can review them on your own. They're in the book. Also, like I said, they have great charts on each chapter. So definitely review those. Obviously, you want to be very careful in your diabetics and your immunocompromised patients. Okay, so necroticizing otitis externa. This is what it looks like. You're going to notice right away. You're going to see swelling in the ear, facial swelling, mastoid tenderness. That's a big thing. Mastoid tenderness. Don't forget that in terms of ear examinations. You want to always document whether they have it or they don't have it. That needs to be documented. So denies mastoid tenderness or is positive for mastoid tenderness. If you see this is a definite need for IV therapy, and admit them acutely for acute care for sure, because you want to watch this to make sure it doesn't get worse. In this particular instance, you are going to use a wick to help keep that medication tight in the canal. And then they have to come back for you to take it out because you're going to pack it in there. Tympanic membrane may not be visible enough due to the edema causing being treated with ototoxic drops. And then keep in mind that necroticizing otitis externa does spread quickly, especially in your diabetics and immunocompromised patients. So they need emergent prescription, and they need referral consultation immediately. Okay, acute otitis media. So the organism that causes this can be bacterial, fungal, or viral. Most cases, it's this Staphylococcus pneumonia, 40 to 50%, H. influenza, or M. catarrhalis. The treatment for most of these is oral antibiotics. Remember, before you're prescribing, you're always asking their allergies, okay? And you want to start first line if they haven't had an antibiotic in the last 30 days, you can do amoxicillin 80 to 90 milligrams per day per kilogram. Or if they have taken this and it didn't work, then you go to this one, amoxicillin clavinate, and you calculate it out based on the patient. Of course, if they have penicillin allergies, you can use azithromycin. For pain, you're going to be giving them NSAIDs, acetaminophen, and very rarely do they need a narcotic. That's a little extreme. Red flags, if they get to that point where they need, like they're saying they need something stronger, then something else is going on. You need to reevaluate. So red flags would be toxic appearing, tender mastoid, and again, immunocompromised patients, you want to get blood work, a CT, or even possibly an MRI. Okay, so acute otitis media is less common in adults, more common in kids, of course. Family history, active or passive smoking, meaning they're around people that smoke. Even if they don't smoke, it can be definitely put you at risk. Anatomical abnormalities, crowded living conditions, trauma, wood burning stove, or a recent upper respiratory infection. Signs and symptoms would be otolgia, otorrhea, fullness, temporary hearing loss, not usually a fever with adults. And then, of course, your differential diagnoses, you want to always consider those. In your exam, you're looking for swollen preauricular and cervical nodes. You want to see your obscured TM landmarks may not be visible. So your tympanic membrane, you may be obscured, meaning it's blocked. The cone of light may be scattered. It might be, the TM might be tense or bulging, and the bones are not visible. Remember, be very careful when you're going into that ear, especially when people are complaining of pain. You don't want to push or shove any, you don't want to force the otoscope in there. Okay, so just be very careful with that. You want to see on exam, you might see some vesicles and associated conjunctivitis on the same side. You want to look for vesicular lesions in the ear canal, and then in that case, you would consider the Ramsay-Hunt syndrome. So otorrhea in the presence of acute otitis media may indicate a ruptured tympanic membrane. So again, we're using amoxicillin or Augmentin unless they have allergies or it's recurrent. So for failure of the first line therapy, we want to consider viral etiology versus bacterial. So just keep that in mind. And chronic recurrent, consider coverage for these particular E. coli or Staphylococcus aureus, or less common Mycoplasma chlamydia pneumonia. This video is fantastic because it really gives you a good idea of what the good ear versus a bad ear looks like. And this I found very helpful because when I first started doing exams, I was like, I still don't get it. But seeing a bad ear really puts it in perspective. And please listen to what the little girl is saying in terms of the symptoms that led up to her ear infection, because it'll give you an idea of how this can sometimes present, especially in a little one.
Dr. Paul here. We've got a young lady with ear pain of all things. Let's go take a look. Hello. Hi. How you guys doing?
Not so good.
Haven't seen you in
I
forever.
know, and every time we come, we bring something new. Where
What's
does
the
it
matter?
hurt? Where does it hurt, sweetheart?
Your ear? Oh dear. Which ear hurts?
This way?
That one? Okay, we're gonna have to take a look. How long has she been sick?
Sick for about 10 days, but the ear just
10
happened
days.
today.
That's right.
Been
She's been
coughing.
coughing, hasn't she?
Yeah. Yeah, there's been coughing for 10 days first.
There's the cough. Oh,
Let's get it checked.
Let's check your heart and your lungs. Your heart sounds really good. Let's see here. Big breath. Again. Excellent. Again. Actually, it sounds a little better than the last time I listened.
It's
For
good.
the viewers, I actually did a whole checkup just to make sure I knew what we were getting into here, and I thought I was hearing a little wheezing, but it's clearing. It's not as bad as I thought before. Take a look. There's your
See your
ear.
ear, sweetheart?
Ooh, see, it's
Look,
red.
See, it's red.
See how red that is?
It's really red.
That is very red. And bulging. You gotta get the sense of 3 dimensions, you know? Does that
It
hurt?
hurts.
Yeah. So just for interest's sake, that's
Wow,
very
that is
interesting.
really red.
I'm gonna try, see if I can get in a little better. A little deeper. There it is. Wow, that's very red and bulging. That, should we look at the other one? Okay.
To see what the normal one looks like?
So now we're gonna flip over so you can look at it. You can look over there. We're gonna look at your other ear. That is, look at
Yeah,
that.
that looks
See that?
great.
Gray, normal. Look at that. Totally normal. I've got my camera rotated wrong. There we go.
It's 1 o'clock.
That's
You can tell the
much
difference.
better. Look at the difference. Isn't that great? That's a normal eardrum, folks, as far as it's kind of that gray. And you can see the light reflex, the shininess. A little bit of wax, but that's really not bad. Let's try that other one just one more time. All right, so viewers, we are looking down the ear canal now. You can see red.
Right, look how red
See
it
that
is. sweetheart.
angry red look in
That's a
the
big
eardrum. It's
difference.
bulging quite far out the ear canal. Down the ear canal, sorry, not out. There we go.
Wow.
That's a pretty good look at it. Okay, excellent. An ear infection that's just on one side, if it's not causing a lot of pain, you don't have to use antibiotics. But when you're in severe pain, the antibiotics will help. It'll get better quicker, quite a bit quicker. And, you know, if you're a parent with a kid who can't sleep in pain, and I've had an ear infection before where it feels like a stabbing pain. So you're going to update my computer for me? Good. Fairly serious, significant with a bulging eardrum, right otitis media, and a star patient. Can you give me 5?
Thank you.
Great, good job. You have anything you want to say to your fans? 5. You did a good job. Thanks for watching. I'm Dr. Paul.
So that was a great visual of acute otitis media, and you saw that nice bulging red ear. Okay, so we just saw an otoscopic exam. So a pneumatic otoscopy is when they do a small puff of air on the tympanic membrane, and absence of movement means it's positive. Okay, so you would do a full head, ear, nose, and throat exam. You would do check the lymph nodes, and of course, listen to the lung sounds just as he did. Usually, you don't really need any other diagnostics. I mean, if you did, you would do either a CBC or consider a culture if they had drainage from their ear. Okay, here is what an ear exam looks like with an otoscopy. Sorry.
This video shows how to examine the ear. The examiner has already washed her hands, introduced herself, explained the procedure, and obtained the patient's consent. So which is your better hearing ear?
My right ear.
And have you got any pain or tenderness?
No.
And can I get you to give me a smile? By asking the patient to smile, you can look for facial weakness, which is one of the 5 cardinal symptoms of ear disease. The facial nerve runs in the medial wall of the middle ear and may be affected by pathology in the ear. All right, thank you. So I'm now going to start by examining the better hearing ear. First, inspect the external ear using the light of the otoscope to help. Look at the colour of the skin and the shape of the pinna. Look for other abnormalities such as tophi and congenital defects, and remember to check for scars. Common surgical scars include the end-oral scar between the root of the helix and the tragus, and the post-auricular scar behind the pinna. Next, otoscopy is performed to visualize the external auditory meatus and the tympanic membrane. There are 2 sizes of speculum for the otoscope. Choose the largest size speculum possible for the patient's ear canal in order to maximize the amount of light passing into the ear and to maximize your view of the tympanic membrane. In adults, the largest speculum is usually used. When examining the right ear, hold the otoscope in your right hand. Hold it like a pen balanced between your thumb and index finger. Extend your little finger and use this to rest against the patient's face. This means that if the patient moves his head, your hand and the otoscope will move with it, and the otoscope will not stab into the ear canal and cause pain. This is of particular importance when examining children. With your free left hand, pull the pinna gently upwards, outwards, and backwards to straighten the external ear canal to allow a better view of the tympanic membrane. In children, pull the pinna down and back instead. Insert the otoscope into the external auditory meatus and inspect the canal for wax, discharge, inflammation, and other abnormalities. Gently proceed down the canal until the tympanic membrane is seen. Move the speculum around to examine the whole of the tympanic membrane and identify the normal landmarks. This is a normal right tympanic membrane. On a normal tympanic membrane, you should be able to see the handle of the malleus, the light reflex in the anterior-inferior quadrant, and the pars tensor. You should look superiorly to see the pars flaccida also. Gently remove the otoscope, continuing to observe the ear canal for any pathology that may have been missed on the way in. Repeat the examination on the other ear. When examining the left ear, hold the otoscope in your left hand, again holding it like a pen between your thumb and index finger, and using your little finger to rest against the patient's cheek. To complete the examination of the ear, the patient's hearing should also be assessed using the tuning fork tests and audiometry.
Okay, so that was a great little review of your ear exam. So this is the tympanostomy tubes. So this is when they have to put in these tubes if we're getting recurrent infections. So a small incision is made in the eardrum, and then the tube is inserted so that you can drain the fluid. You see it frequently in pediatrics. When you're looking into the ear, you'll see like a blue or green tip of the tube when you're examining them. And this prevents, the chronic infections, especially if there's a ruptured tympanic membrane. So ruptured tympanic membrane usually ruptures from a buildup of fluid behind the eardrum or behind the tympanic membrane. It's otolgia, like ear pain, pretty significant ear pain, and then prompt relief with drainage. And they may see it on the pillowcase, and they probably will have hearing loss. So things that can cause it are diving, high altitude trauma, or blast injury. And it's just like a sudden severe change in pressure that can cause this for sure. You definitely want to make a referral to an ENT. It may resolve in several weeks, but larger ruptures require intervention. So in these particular patients that have a ruptured tympanic membrane, you want to avoid ototoxic drops like aminoglycide, arugulin, and just be very careful with that. Okay, otitis media with effusion. They call it OME or a glue ear. It commonly develops weeks or months after acute otitis media. Again, it could be barotrauma, or AKA airplane, scuba diving, seasonal allergy. You need to make sure you differentiate it from acute otitis media versus otitis media with effusion. So in the exam, you're going to see air fluid levels, bubbles, serous middle ear fluid, and then you're not going to see inflammation. You want to make sure you're doing your Weber and Rhine, and you're going to find lateralization to the affected ear. And remember, lateralization means they can hear the sound in only one ear, or the sound is louder in one ear. Antibiotics are generally not indicated unless if it's persistent and recurrent. You want to consider treating the cause. Obviously, if it's caused by allergies, we need to remove the allergen. And then possible implications for children that are still little is due to hearing loss. And we definitely want to refer again to an ENT if they continue to have this issue. So patient education with all ear infections or ear issues. You want to make sure, number one, that they finish all antibiotics that were prescribed to them. Reduce the risk when able, avoid the swimming, avoid diving, avoid airplanes, anything that'll cause a lot of change in pressure. You want to obviously avoid getting the ear wet, especially when the tympanic membrane has ruptured. You want to avoid flying and diving. Follow up if the symptoms do not improve. So when do we make our referral to ENT? Is for tympanic membrane rupture, for frequent or recurrent AOM or OME, if they have any vertigo, ataxia, or their hearing does not improve. Primary prevention to prevent these ear infections would be obviously to receive appropriate vaccinations in childhood, which could definitely reduce the number of AOM. Okay, cholesteatoma. So this is the growth of keratin-producing squamous epithelial cells in the middle ear or the mastoid air spaces. It's characterized by persistent foul-smelling discharge. It may be watery. It can cause facial paresthesia, numbness, and hearing loss. We definitely want to refer to an ENT because it can cause hearing loss, and the surgery is the best treatment. Okay, so rhinitis, which is inflammation of the nasal mucosa, or they also call it coryza. It could be acute or chronic, allergic versus non-allergic. There's definitely multiple etiologies for this. It could be infectious, it could be irritant related, could be vasomotor, hormone related, medication overuse, or atropic, which is primarily in geriatric patients. It's usually but benign. The biggest issue with rhinitis, which is constant runny nose or inflammation of the nose, is just the quality of life. I mean, if untreated, it could lead to sinusitis. It could lead to otitis media externa. It could lead to hearing impairment, nasal polyps, aggravation of asthma, and of course, sleep apnea. So symptoms, sneezing, itching, sometimes the symptoms that come with it are what can differentiate it from just plain old rhinitis. So we want to look to make sure they don't have any fever, what medications they're using, how old they are, their environment, what's the level of cleanliness in the house, do they have a lot of animals, dander. Those are things that you need to really look at. Okay, so obviously managing it depends on what's causing it, right? So if it's rhinorrhea, we want to get a humidifier and a vaporizer and talk about oral decongestants, as well as anything for a cough. We're going to need some dextromethorphan. And then if we needed to give them codeine in their cough suppressant just to help with sleep, we can do that too. If it's allergic, like if it's being caused by allergies, we want to reduce the allergen exposure. We want to consider Flonase because it'll bring down the inflammation, or an oral antihistamine. We want to consider referring the patient for for allergy testing to see what's causing this constant runny nose, and then possibly immunotherapy to look at allergy shots. They'll give them little shots of different allergens to see what they have a reaction to. If it's rebound rhinitis, we want to stop decongestants and maybe do a short course of steroids. And if it's atropic rhinitis, we want to look at doing an ointment of bacitracin inside the nose a couple of times a day until the nasal crusting and foul odor has been eliminated. We want to look at expectorants like guaifenesin every 4 hours is needed. And then, of course, you can consider saline nasal drops, which they sell right over the counter. Okay. Allergic rhinitis, you're going to see a boggy mucosa, thin, clear discharge. Usually it's diagnosed based on the history. You could do a right stain or allergy scratch test if you wanted to. Again, check the med list to see if they have any culprits on there, like NSAIDs, beta blockers, ACE inhibitors. And remember that boggy mucosa, you're going to see that it's pretty obvious when you look and you do an assessment on the patient. And again, that thin, clear discharge. Okay, be conscious of discharge. You want to really look at the color. Where it's not green, it's not yellow, it's thin and clear. Okay, that it's definitely going to differentiate just an allergy versus an infection. Okay, sinusitis and rhinosinusitis. So sinusitis is inflammation of the mucous membranes of paranasal sinuses. Rhinosinusitis is sinusitis with concurrent inflammation of the nasal mucosa. It could be acute, subacute, or chronic. So risk factors obviously are weather, whether it's winter, spring, the fall, smoking, allergy, structural issues, whether it's polyps or something is actually in there, like something foreign. Sneeze against a closed mouth, again, that can cause pressure and can definitely damage the sinuses. Change in temperature, if your house is very hot or dry, can cause some issues. Air travel, flying, diving. Remember, any change in air pressure, definitely any dental abscesses can lead to these issues. There's multiple causes for these sinusitis versus rhinosinusitis. So sinusitis, we're looking at viral, bacterial, fungal, or allergic causes. Acute viral rhinosinusitis the main predisposing factor can be so the main predisposing factor for acute bacterial sinusitis is AVRS. So it's the same pathogens as viral upper respiratory infections, which is like 30%, coronavirus, Coxsackie virus, respiratory syncytial virus. ABRS is usually caused by Streptococcus pneumonia. Fungal is usually caused by Aspergillus. And then, of course, you have allergic and irritants, which are like your smoke, any kind of chemicals. Those can be predisposing factors for acute bacterial sinusitis. Okay, so acute sinusitis. They may have recently had a upper respiratory infection, so you need to differentiate viral from bacterial. They may have a history of asthma, allergies, recent dental infection, diving and swimming. They could have been diving or swimming and then got this. So one of the things I definitely want to point out in terms of just primary prevention, you always want to be following up with your patients about their dental follow-ups. That's one of the things you're going to ask your patients, like, when was the last time you went to the dentist? How often do you get your teeth cleaned? Do you have any history of cavities, any infections in the mouth, anything of that nature? Again, in terms of historical issues that may have led up to the acute sinusitis, they may have some anatomic abnormalities. Obviously, they may have some facial or dental pain. Things you're going to maybe hear is that the pain is worse in the morning or when they bend forward from the waist. It can be severe. Headaches, yellow-green nasal discharge. They may or may not have a fever. You're doing an ear, nose, and throat exam, checking the lymph nodes and the heart and lungs. So signs and symptoms of sinusitis: nasal congestion, obviously, mucopurulent rhinorrhea, okay, feeling of pressure inside the head, cough, sore throat, malaise, fatigue, progressive, dull to throbbing pain. They may get eye pain, which is like around the ethmoid sinus. They may get pain in their cheeks and upper teeth, which is your maxillary sinus. And then your frontal sinus, you may get some pain around the eyebrow area. They could definitely have swollen nasal mucosa, which definitely red, swollen, you'd think infection. Pale, boggy, watery, you're thinking allergic. So remember, infection, you're looking at swollen and red. That's when you're thinking it's an infection versus just allergies causing the sinusitis. Allergy would be pale, boggy, and watery. You're not seeing red, you're not seeing angry. You're seeing pale, boggy, and watery in an allergic sinusitis. And of course, in both cases, the likelihood is that they're going to be tender to palpation and percussion. So diagnostics are usually just not really done unless there's a toxic appearance. If you're concerned there's infection or the patient's immunocompromised, if they have a fever, then we're going to definitely want to do a CBC. Or if they don't have any improvement after 4 to 5 days of therapy. So we could do x-rays, we could do CTs, just depends on what you're looking for. If you're looking for air fluid levels, you want to do complete ossification of the sinuses, or if you're looking at the soft tissue or you want to think about the brain, then you're looking at an MRI. Okay, so we're always looking at our clinical guidelines for best treatment, especially if you want to make sure you're doing the best treatment and you're up to date with that. You want to definitely have up to date on your phone, on your phone. That's a great resource to go to for the best, most current treatment. So an oral antibiotic is first line for bacterial sinusitis. And that would be amoxicillin. You have a whole list of other choices here, but keep in mind when you're treating sinusitis, you want to treat the specific type. So, you want to do a short course of oral or nasal decongestions, nasal steroids, short course, everything is short. They don't stay on these for very long. Okay. When to treat sinusitis. So this is, as a clinician, sometimes you have to really weigh the pros and the cons. Because a lot of the times the patients will come in early, especially if they've had this before, if this is a recurrent, and they'll just say they need the antibiotics, and they sometimes don't even want to come in for the actual exam. They're just demanding the antibiotics. But you have to be very careful with that. So sometimes viral sinusitis will improve after 5 to 10 days. Most guidelines recommend supportive treatment until then. Patients with more severe presentation like fever, pain, if they have comorbidities like diabetes, then you definitely want to treat them a little bit earlier with antibiotics. It's not uncommon for patients to start with a viral upper respiratory infection or a cold and then have lingering symptoms to develop a secondary or superimposed bacterial sinus or ear infection. Definitely listen to the history. Like, you want to see how this came to be. Assess for maxillary facial pain, check for purulent discharge, check for a fever, and make sure you're looking at that tympanic membrane. Okay, so red flag. So periorbital cellulitis. And that's what this is. See all this swelling? And then it's a lot of swelling, these poor babies. And then we have sinus cavernous thrombosis. So what we're watching for, these are red flags, emergency situations, right? So we're watching for worsening toxic appearance. These are things, when you see this is 911, okay? Any facial swelling, you want to be very, very careful with, okay? So it could, obviously it's indicating that we're having a spread and a worsening of infection. It's rare, but there is a high mortality rate. So you have to make sure you deal with this right away. And when you're documenting your assessment of your eyes, these are one of those things that you want to document you didn't see. So you saw no periorbital swelling. You have full and intact for your EOMs. You want to make sure all of that's documented. Okay, nasal septal hematoma. So presence of nasal septal hematoma is a significant finding. It may indicate a facial fracture. So it's usually from trauma or abuse, all right? Again, you want to make sure that you're documenting that you assessed it and there was no trauma to the nose, face, so that you made sure that you are documenting that you did assess for that. Okay, so a nosebleed, determine the underlying cause. Okay, so epistaxis is also known as a nosebleed. When I worked as a school nurse, oh my God, I saw these all the time. I don't know what kids do to themselves to get these all the time, but there's definite underlying causes. It could be one of these few things: trauma, dry air, nose picking, foreign bodies, especially in children, coagulopathies, neoplasms are less common, and medications that can lead to nosebleeds. Obviously, we know warfarin, any blood thinners, nasal sprays, and cocaine. Cocaine is a big one for nose issues. Okay. So if it's an anterior nosebleeds, it's usually from the Kieselbach's plexus, which is a very well vascularized area in the nasal mucosa, and it is the most common type of nosebleed. That's your anterior. Posterior nosebleed is definitely more serious. It's usually from vascular disease, ruptured vessels, ruptured aneurysms. It may present as hemoptysis or blood in the vomit. Okay, so if your patient is vomiting up blood or coughing up blood, the likelihood is it's from a posterior nosebleed. So if it is a posterior bleed, we need to refer to a specialist, and the likelihood is they're going to need surgical intervention. Okay. If it's an anterior bleed, which is the most common one, you're going to apply firm pressure to the cartilage for 10 to 15 minutes without letting up. Seated upright, leaning forward. It used to be that we would tell the kids lean back. Now the evidence-based practice shows that leaning forward is the better practice. They do sell like special ice packs for the nose. If that's something that you ever want to look into, if that's a frequent issue in your practice. But you could just use an ice pack to help alleviate the bleeding. Vasoconstricting drugs would be phenylephrine, or you could do a cautery drug like a silver nitrate stick, but that can definitely be uncomfortable. So hopefully you won't have to use that. You can pack the anterior chamber with gauze. It's like a nasal tampon for 2 to 3 days if it's really bad. But if you're finding that that's a necessity, I would definitely consider getting this patient to a specialist. And obviously you want to determine the cause and educate the patient on how to prevent that, the nosebleeds going forward, and when to, seek emergency treatment. Okay, so in terms of applying this all to practice and pearls for prescribing antibiotics, these are remember what I said in your book, in your textbook, they have great charts in each system, each chapter for each system of the common antibiotics for prescribing. You want to begin to learn the common pathogens in each system. You want to categorize bacteria by gram-positive or gram-negative or atypical. Learn the first line of treatment for each one. And then keep in mind, many of the same organisms causing infections above the belly are the same. Therefore, you'll see antibiotics such as amoxicillin used for multiple diseases of the head, nose, ears, and throat. You want to avoid prescribing 2 antibiotics when treating more than one condition. You want to select the option with the best and likely expanded coverage for both. Okay. If the same antibiotic is recommended, you want to use a higher dose to be sure to cover both infections. And it may be a first or second line recommendation. Okay. Okay, so guidelines and antibiotics. Again, we're talking about prescribing. So we want to use the best judgment, consider comorbidities, look at all of our exam findings, but never be bullied into prescribing if it's not truly indicated, no matter what your patient tells you. A lot of the times patients come in and the first thing they say is, I need a Z-Pak, doc. And that's not how it works. You really have to, do your full review of systems and your physical exam and really make the best decision for your patient. If you decide you're going to not follow the guidelines and there's you find that you're going to prescribe off the guidelines, you need to document your reasoning why. Okay. Again, if for multiple infections, you want to select the antibiotic with the best coverage for both. You don't want to be prescribing multiple antibiotics. If your patients have been on antibiotics before, you definitely want to see what they have to say in terms of what worked and what didn't work. Definitely check the validity of that, because sometimes people get mixed up. They don't even know the names of their medications and they may not be accurate. So check the chart, check the pharmacy, call the pharmacy, see what they were on before. And then always consider before prescribing, especially in females, last menstrual period, if they're pregnant, and what their allergies are. You want to, of course, keep in mind what your patient's insurance is. If they don't have insurance, you're definitely going to want to prescribe generic because it's cheaper. And you definitely want to consider any patients that are diabetic or immunocompromised before prescribing. Okay. Application to practice using your resources. As if you're in the clinical setting, where might you access current clinical guidelines to treat strep or GABS, pharyngitis in the adult patient? Using a prescribing reference, locate the prescription information for prescribing pen VK for GABS in the adult patient. Okay, so again, in terms of use current clinical guidelines, one of the best places to find quickly is Up to Date. That's a great resource. Hopefully your institution has that, because it is expensive, but a lot of institutions do cover that, and you have access to that through your institution. So find out where you work what you have access to in terms of references, because that's really helpful. And then, of course, the Sanford Guide gives you the best, most antibiotic options that are available. Okay, that's it for this PowerPoint. There's one more, and that's part 2 of our lecture. Thanks, guys.